Alright, let's get to the laboratory testing now. As mentioned in chapter 11, the most cardiac specific as far as heart failure testing goes is BNP. Since BNP again is produced only by the cardiac ventricles, the heart ventricles in response to stretching, which occurs in heart failure, this is going to easily rule out other causes of shortness of breath, such as pulmonary embolism, because these patients come in with the same exact symptoms, whether they're having a heart attack, a pulmonary embolus, they're in heart failure, all of them present with shortness of breath. So to easily rule out, the doctors usually have a set of blood work that are ordered on everybody that presents with shortness of breath, and as soon as we get an elevated BNP result, then that makes their job easier to rule out other causes. Okay, it will point towards heart failure, and then we can treat the patient appropriately. Now, as stated here, in addition to BNP, the patient's hemoglobin and hematocrit levels may be low because the patient is in fluid overload. So blood volume, since blood volume is increased or preload is increased, then that would result in dilution of the blood. So the patient didn't really lose blood. Okay, there's no bleeding that occurs here, but the H&H, as we studied in chapter 11, when we compared fluid overload and fluid deficit, there is decreased hemoglobin and hematocrit in fluid overload as a result of hemodilution, meaning the blood is more diluted. Urinalysis may also reveal proteinuria, and there is microalbuminuria that results. Although this is an early indicator of heart failure before BNP rises, however, patients aren't going to be tested for this first, because most of the time the patients already present with symptoms when they come into the hospital. But before they even became symptomatic, microalbuminuria already occurs. Now, this is your evidence that cardiac output is also already very low, that the kidneys, of course, this is now in response to sympathetic nervous system stimulation. When shunting of blood occurs, vasoconstriction occurs, so blood is shunted from the periphery to only the vital organs. Hence, only the heart, lungs, and the brain receive most of the blood supply, sacrificing the kidneys. Now, this shunting of blood, which results in low blood flow or low perfusion to the kidneys, causes vascular damage in the nephrons, increasing their permeability. As a result, large molecules like albumin, which normally cannot pass through capillaries, are now allowed to pass through. So this is again an early indicator, but not necessarily one that we would notice right away. So since the patient in heart failure will most likely be short of breath already, then most of the time we will rely on BNP. But microalbuminuria remains the earliest warning detector. Other tests here, like X-rays, tell you how long the patient may have been in heart failure, because it will show some remodeling, some cardiomegaly. This is the most common test, along with an echocardiogram that is done. These MUGA scans are very expensive. They are not routine tests that doctors will order to diagnose heart failure. Most of the time they're just X-rays and echocardiograms. Let's pause on invasive hemodynamic monitoring for a minute. Now, let me explain this concept. People in heart failure, for you to have a good outcome, doctors need to monitor the real-time blood pressure inside the heart rather than outside, because once the patient becomes symptomatic, it really means the patient is already in heart failure. Now, the patient outcome would be so much better if we see the heart failure unfolding before your eyes before the patient even develops symptoms. Okay, so hence we have invasive hemodynamic monitoring. This is accomplished through a Swan-Ganz catheter, or they also call that a pulmonary artery catheter. Now that catheter is going to measure not only left side heart failure as stated here. Left side heart pressure is also called pulmonary artery pressure, or pulmonary artery wedge pressure, or pulmonary capillary wedge pressure. Whichever term you're using, this is going to measure pressure on the left side of the heart, specifically the left ventricle. Let's go to chapter 38, since that's where it is described. Since we're also measuring the left side, we're also measuring the right side at the same time. So I'll demonstrate this using a YouTube video. Swan-Ganz catheter is the name of the catheter that is inserted.
This is a demonstration of flip format.
So in this video, the physician will insert a catheter. It's like a Foley, but this is so much more sophisticated than a Foley. It looks like a Foley. I mean, it has a balloon at the tip, but it has two sensors on it. So this is threaded. All you can see here is the heart, but the point of insertion is really on the neck. It's on the jugular vein. So the doctor inserts the catheter through the jugular vein, and of course he can't see what we're looking at on the screen. The doctor will be looking at the monitor. The video should show the monitor on the right lower hand corner of the screen. So this is the air that they use to inflate the balloon. Now, it's necessary to inflate the balloon because this is a flow directed catheter, meaning flow directed, the catheter will be carried by the bloodstream. We are not forcing this in, because this is a very soft catheter. There's no metal wire inside it. It's very soft, so the blood has to carry the catheter forward. Of course, there are complications for the procedure, but most experienced doctors should be able to put this in quite easily. But of course, there are always complications. I mean, it gets crowded inside the heart, especially in the ventricle, because you have all these chordae tendineae here. Things can go wrong, but that's not our concern for this video. So let's just observe how it is put in and why it shows us the measurements that it does. So if you look at the screen here, this is all the physician will see on the right side. So he knows that the catheter is in the right atrium because of the pressure reading right here. As soon as he enters the ventricle, notice that the pressure rises drastically. Okay, so here you see the difference between the pressure when you're in the right atrium and as soon as you enter the right ventricle. You can just imagine how strong or how high the pressure is inside the ventricle, because it would spike almost double or 4 times that of the pressure in the right atrium. So let's proceed. So again, this is a flow directed catheter. The blood will just carry the catheter via the balloon until it changes the pressure here. So as soon as it leaves the right ventricle, pressure changes again. Okay, so telling the doctor where exactly the catheter is. Again, remember, the doctor cannot see this. He cannot see what's going on inside the heart. All he's doing is just advancing the catheter and looking at the pressure monitor. So he keeps going until he sees the pressure getting wedged right there. So you see the wedge pressure now. So that means the pressure dropped because he actually occluded the pulmonary artery. Now this occlusion, hence some books will call this pulmonary artery occlusion pressure. That's also another name. Since the artery here is completely blocked, so you'll see where exactly the catheter is lodged. It's right at this bifurcation here. So this can go either to the left or right pulmonary artery, and as soon as it's there, you'll see the doctor will deflate the balloon because we don't want to obstruct blood flow. So it will deflate the balloon and then leave the catheter right there. Now let's back up a minute. So since this catheter is going to be left right there on the pulmonary artery, on one of the pulmonary arteries, this is an indirect measure of the left side of the heart. Let me demonstrate. So if you look here, because we don't need to put the catheter all the way to the left ventricle. It's impossible to do anyway, although we can, but we don't need to. This placement of the catheter right here is enough to give you a indirect measurement of the pressure in the left ventricle. How? Because anything going on in the left ventricle will be reflected in the lung, as I explained in the previous video on the pathophysiology of the left side heart failure. When there is congestion of blood due to left ventricular failure, and there will now be backflow of blood in the left atrium, that blood in turn will be going back into the lungs, causing congestion. So this sensor right here, the tip of the catheter, which has a sensor, will pick up the increased pressure in the pulmonary circulation. Not directly, but indirectly, meaning whatever goes on in the left ventricle or on the left side of the heart will naturally be reflected in your pulmonary artery. On the other hand, on the right side, if you see the part of the catheter that is lying on the right ventricle and the right atrium, this pressure sensor here on the right atrium will be measuring pressures on the right side of the heart. Okay, so now you have an instrument giving you real-time blood pressure monitoring inside the patient's heart. So you know exactly what's going on there even before this patient presents with symptoms of left side or right side heart failure, allowing the doctor and of course the nurses to give interventions even before symptoms develop. That would make for a very good patient outcome. Another name for right atrial pressure is CVP, or central venous pressure. Let us go to chapter 38 for a minute just to see the numbers, because on the exam I will not be interpreting the numbers for you. I will only say what the measurements are, and it's up to you to interpret what the numbers mean. So let's go to chapter 38, and we are looking for the measurements under hemodynamic monitoring. Okay, right here. So this is hemodynamic monitoring under chapter 38. The measurements are right here, page 780, 9th edition. So here is your pulmonary artery catheter, and these are the measurements. Normal right atrial pressure is between 1 to 8 millimeters of mercury. And because, let's say for instance, if the patient develops right side heart failure, what do you think will be the numbers reflected on the pulmonary artery catheter? What pressures will it most likely pick up from the pulmonary artery catheter that reflects right atrial pressure? Will it still be 1 to 8, or will it be some number like 10 millimeters or 12 or 15 millimeters of mercury? Those will be the numbers if the patient has right ventricular failure. On the other hand, if let's say this is a patient who same thing, the patient had right side heart failure, and then let's say the doctor ordered to give diuretics, then the nurse ends up giving too much diuretics. If the patient ends up with hypovolemia or dehydration as a result of too much diuretic therapy, what do you think the right atrial pressure will show? It will be 1 or below. Do you understand the application now? Okay, let's go now to the left side. So the left side heart pressure again is reflected in the pulmonary artery wedge pressure. The official name is left ventricular end diastolic pressure, or LVEDP. So this is the the indirect measure of the left side of the heart, and the normal values or normal readings are between 4 and 12 millimeters of mercury. Now let's say for instance, if a patient suffers from left side heart pressure, what do you think the reading will be on the PAWP? If you said it will be elevated, that is correct. So numbers like 15 up to 20 or higher will mean that the patient is in left side heart failure. On the other hand, like the example I gave you, let's say this same patient was given way too much diuretics, or let's say a patient who is bleeding to death, what do you think this reading will be? If you said it will be low, like below 4 millimeters of mercury for instance, that is correct. I hope you understand the application and the usefulness of a pulmonary artery catheter. Alright, let's go back now to chapter 35. We will now go to drug therapy. Okay, we just left with diagnostic procedures, and then we just finished explaining hemodynamic monitoring. So again, hemodynamic monitoring is not only used to diagnose a patient with heart failure, but it can also be used to monitor patient's response to therapy. What is the effect of the interventions that a nurse has implemented? How did the drugs that you gave this patient affect the patient? Did it improve or did it worsen your patient's condition? All in real time, before this patient even presents with any of the symptoms shown in charts 35-1 and chart 35-2. And of course, that makes for a really wonderful shift if you can anticipate rather than react to your patient's signs and symptoms. Alright, first intervention for any patient in heart failure, because this is a perfusion, remember. And we may talk about different causes, but the number one basic concept is this is a perfusion problem. There is a problem with oxygen transport. Alright, so the patient has low cardiac output. No matter what the cause, there is the lack of oxygen delivery to the tissues. So first intervention is always oxygen. So we give oxygen, and then of course elevate the patient's head of the bed. Later we will also learn that elevation of the head of the bed must be used cautiously. If the patient's systolic blood pressure is less than 100 millimeters of mercury, the head of the bed should not be elevated more than 10 degrees, because elevation of the head of the bed, like high Fowlers or semi Fowlers, will actually drop the blood pressure. So place the patient's head of the bed up only if your blood pressure is at least 100 millimeters of mercury systolic. Alright, so our next action after oxygen is of course drug therapy. I mean, there is no other way we can improve this patient's perfusion except through drugs. What I'm saying is you cannot use therapeutic communication to improve this. I mean, the patient will probably die before your therapeutic communication starts working. So an acronym for our drug therapy, because there's a lot, is doables. I have it right here. The drug therapy, by the way, is still based on these same concepts. I mean, these same three elements, meaning we will give this patient drugs that will improve contractility of the heart. We will give them drugs to decrease preload, because we know that a high preload increases oxygen demand, which it will increase the heart's workload. And then finally, we need to decrease afterload, because we know that increased afterload, or if the vessel is constricted, increases cardiac workload by increasing oxygen demand and oxygen consumption. So we need to decrease both preload and afterload, meaning reduce cardiac volume, yes, reduce blood volume, and also reduce cerebral systemic vascular resistance by causing dilation rather than vasoconstriction. Right? So we need to stop the sympathetic nervous system stimulation, or the systemic sympathetic nervous response, because that causes increased heart rate and vasoconstriction, which increases afterload. We need to stop the RAS, because the RAS causes both vasoconstriction, which increases afterload, and increased blood volume by reabsorbing sodium and water through aldosterone. So we need to stop all these compensatory mechanisms in order to help the patient in heart failure. So drugs are here. We have our acronym. So this is not original, this is not my own. I learned this from other textbooks. The acronym is doables. Now it's D stands for digoxin and diuretics. Oxygen, of course. For A, it is ACE inhibitors and or ARBs. Let's say a patient can't tolerate ACE inhibitors, so we'll use ARBs instead. We'll give typo here, sorry. This is supposed to be beta blockers. Okay, easily fixed. So we have beta blockers and human BNP. This human BNP, you remember BNP that was released by the ventricles of the heart in response to fluid overload. We have a drug that is derived from human BNP. We call that Natricor. It is an expensive drug, but is very effective in causing vasodilation, which decreases afterload, as well as diuresis, which causes decreased preload. We will of course put the patient on a low sodium diet because sodium causes water retention, which will increase preload. We're not going to have the patient exercise during the acute episode, of course, but exercise in this case would be afterwards. If the patient, once the patient is already stable, then we will encourage low impact exercise to strengthen the heart, and of course we would like to encourage the patient to stop smoking. So let's look at each one. So they are in table 35-3. Now what follows here, by the way, you'll notice that I did not address all the drugs listed on this table because they are not common. So I'm only listing doables, which are the most commonly used drug therapy for heart failure. And the following paragraphs, I won't read the fine print on the paragraphs, especially on the side effects. I will leave you responsible for reading the side effects because questions on the exam will be on nursing responsibilities. You need to know the common names of these drugs. No, we'll use generic, by the way, not brand names. Make sure you understand that for each drug, since they're the same classification, they typically have the same side effects as well. So for instance here, ACE inhibitors and ARBs, for these drugs, because they suppress the or they inhibit the ACE, angiotensin converting enzyme, therefore it stops the vasoconstriction and the aldosterone secretion. So if the patient now loses sodium, naturally they will keep potassium because of the sodium potassium pump. So you would monitor the patient for hyperkalemia. And we just finished chapter 11 talking about signs and symptoms and treatment of hyperkalemia. So these are, I'll hold you responsible for those. They've been making these combination drugs now. Entresto is one. It's a combination of both an ACE and an ARB. Here is human BNP. Here is the Natricor, or the generic is Nisiretide. No, it works just like BNP that the body releases, causing diuresis and vasodilation. Now, please read all drug alerts. They are very testable. Here, these are drugs that reduce preload, starting with nutrition therapy, which of course is low sodium diet, and we already know the equivalence of how much weight is retained and how much the equivalent is in fluid amounts. We did that in chapter 11. For drugs that reduce preload, of course, this would be diuretics are the number one. They reduce blood volume, hence they reduce preload. Again, I'd like to give you a responsibility of monitoring the side effects. You know that loop and thiazide diuretics cause hypokalemia, and you're expected to know again the expected signs and symptoms of both hypokalemia from diuretics and then hyperkalemia from ACE inhibitors. And finally, we have drugs that enhance contractility. Number one drug is Digoxin. These are the effects of Digoxin on the body. It increases contractility while reducing heart rate, meaning it just makes the heart more efficient. It beats less but beats stronger each time. It does increase oxygen consumption to a certain extent because of that increased contractility, but it kind of balances out because you do reduce the heart rate at the same time. Hypokalemia can result from, hypokalemia can cause digoxin toxicity, meaning as with most drugs, the kidneys are the ones responsible for eliminating the drugs. So in addition to hypokalemia, meaning low potassium levels causing digoxin toxicity. The reason for this is the digoxin enters the cell via the sodium potassium pump. So therefore, if your potassium levels are low, digoxin cannot enter the cardiac cells. As a result, digoxin builds up in the blood and then causes digoxin toxicity. Please find out the normal levels in your textbook. I won't tell you. I'll leave you responsible for finding the therapeutic as well as the toxic levels of digoxin. Take note that toxicity, in addition to hypokalemia, can also result from kidney function. Let's say if the patient has poor kidney function, let's say they're already in kidney failure, since the kidneys cannot eliminate digoxin, then that naturally means that the patient will have digoxin toxicity as a result of the drug accumulating in the bloodstream. And here are beta blockers. Again, please read the details. There is a difference between metoprolol tartrate and succinate. If you can't find it in the book, please look it up in your nursing drug handbook. And that's about it. We do sometimes give spironolactone. That's another type of diuretic. This one is of course a potassium sparing diuretic. But the danger here, of course, instead of hypokalemia, this patient will have hyperkalemia as a result of this drug. And that's it. Okay, I'll just use this one as the last one before I wrap up this video. This is a non-pharmacologic therapy to help a patient with heart failure. Cpap. Cpap is normally used for patients with sleep apnea. Okay. However, the Cpap can also improve cardiac output by decreasing afterload and preload, right here, and dysrhythmias as well. Meaning, this positive airway pressure increases intrathoracic pressure to some degree. Meaning, remember that the lungs are flanking the heart. Inside the torso, they share the same thoracic cavity. The heart is in the middle. Then you have the right and the left lung flanking the heart. If you increase intrathoracic pressure, that would actually press the heart extra long compared to normal breathing. So if you put the patient on a Cpap, that will increase, it will hyperinflate the lung and causing increased intrathoracic pressure, thereby compressing the inferior and the superior vena cava to some degree. That compression will lead to decreased venous return. There will be less blood returning to the heart. Therefore, indirectly, it will lead to a low preload. Can you imagine that? I hope so, but if you have questions, I will address it in class. Alright, so we will not be testing these surgical management. We are not. These are advanced therapies, ventricular assist devices, so we're not testing them. These are critical care topics. Chart 35-3 just tells you again, this is not any different from chart 35-1 on the second column of left side heart failure signs and symptoms. This is the same thing. And let me go to the discharge now. The discharge teaching for a patient in heart failure is in table 35-4. So this is how you teach the patient to manage their heart failure. Remember, heart failure is a chronic condition. There's the only treatment or the only cure is a new heart. So the acronym is MAWDS, MAWDS. So that stands for your medications, activity, weight, diet, and symptoms. Now, as far as the symptoms goes, because it says here, note any new or worsening symptoms and notify a physician, healthcare provider immediately. Now, you need to tell the patient what exactly are these new or worsening symptoms. They are found right here under the action alert. So there are 6 items here that if any of these symptoms occur, they will indicate worsening or recurrent heart failure. Okay, so this is therefore the S in the MAWDS. So they are rapid weight gain, and it specifies here how much weight gain is bad, decrease in exercise tolerance, and so forth. And here's another chart for teaching patients who are on beta blockers and digoxin. Please read it on your own. And nutrition, again, low sodium. Just remember that there are varying degrees of sodium restriction. Please read the details. And finally, we will also discuss advanced directives with these patients. And that's the end of heart failure.